Welcome to the deep dive. This is a bit of a different one for us. We're treating this as an orientation.
Yes. Think of it less as a typical deep dive and more as a personal invitation.
An invitation into a space we've built, really, for you, the lifelong learner in medicine.
Because that's who this is for.
Right, if you're that person who's running between shifts, or maybe you're stuck in traffic exercising and you're just trying to, wrap your head around some dense concept you read about.
You can't exactly pull out a textbook.
Exactly. This project is built for those very moments. So today, we're going to take our time. We're going to lay out the conceptual map for what we call clinical deep dives, or CDD.
We really want to explore why it exists and maybe more importantly, why we believe it's different.
And it all starts with a core belief, doesn't it? There's a philosophy behind this whole thing.
There has to be. Otherwise, it's just more content, and nobody needs that. The core belief, the idea that underpins every minute of audio we create, is this. Medicine is best understood not through rapid-fire memorization.
The kind we all did for exams.
The kind that, vanishes the moment you step out of the exam room. It's understood through the patient disciplined cultivation of curiosity, synthesis, and deep conceptual clarity.
I love that distinction you make. Synthesis over simple recall. It's so crucial.
It is.
You can cram enough isolated facts to pass a multiple choice test. We've all done it. But when you're standing at the bedside and a patient presents with a truly complex multi-system issue.
Which is most patients eventually.
Right. Let's say a 70-year-old with an acute kidney injury, but they also have chronic heart failure, and now there's this new onset confusion. That is precisely when fragmented knowledge completely fails you.
It's not just unhelpful, it can be dangerous.
That's when you need that capacity for synthesis.
Exactly. Synthesis is the ability to connect the dots in real time. It's what transforms a really stressful recall drill into a practice recognition of conceptual patterns. And that right there is what we're aiming for.
So clinical deep dives. It's a learning initiative housed within the Medlock Holmes program.
Right. And it offers these guided, structured audio explorations of medicine and surgery. The whole point is to take the inherent density of medical knowledge.
Which is immense.
Immense.
Yeah.
And make it accessible and flexible. So you can engage with it wherever you are.
And that portability mission is so key. I think we need to be really explicit about that. We are trying to fill the gaps in a clinician's life.
We're not competing with your dedicated study time.
No. We want to claim the moments that are otherwise lost. The half-hour commute, the walk with the dog, the time on the treadmill.
We all know that feeling, don't we? Of wanting to engage rigorously with deep concepts, but time is just too thin. You're not going to open a 1,200-page textbook for 15 minutes.
It's just not practical. So we believe that rigorous medical learning shouldn't be confined to your desk.
And this is the crucial part. We emphasize portability without superficiality.
That's the trap, isn't it? So many digital resources are just summaries of summaries.
It's the plague of modern digital learning. Efficient, shallow summaries. Our learning goal here is incredibly specific. We want to help you build a coherent, durable mental model.
What does that mean in practice, a durable mental model?
It means that when you are under pressure, you don't feel like you are desperately trying to retrieve an isolated fact about, say, a drug dosage or a specific differential diagnosis from a list you memorized.
You're not just searching a mental database.
No. You want to feel a sense of recognition. That's the feeling. It's when your deep understanding has shaped your intuition so thoroughly that the right path sort of emerges. Not because you memorized a protocol, but because you genuinely understand the underlying mechanism.
We design these deep dives to slow the concepts down. Just enough to let that meaning emerge.
It's about tracing the lineage of an idea.
Right. We want to connect the molecular mechanisms to the symptoms you see. We link the anatomy to your examination findings. We try to bridge physiology to pharmacology.
And integrate pathology into the clinical trajectories you'll actually encounter. It's all about building a coherent fabric where every thread supports the next.
Not just collecting a pile of scattered, isolated pieces of information.
If you approach medicine as an integrated, coherent whole, that durable mental model ensures your clinical reasoning is grounded. It's what allows you to, say, anticipate the progression of a disease rather than just react to its current state.
It also supports flexible thinking, right? For when a patient's presentation doesn't neatly fit the textbook profile.
Which, as we all know, is often the case, more often than not.
Okay, so let's unpack this a little more. That idea of durable, integrated knowledge, it sounds fantastic in theory. But where did the actual spark for this idea come from? I know it wasn't a corporate publishing decision. It had a very specific, very human origin story.
You're right. It began very quietly. It started in conversation, not as some predefined publishing project. It truly emerged from an ongoing exchange.
A family conversation, actually.
Yes, exactly. It took place starting in 2025 between Dr. Manan Kaur and his daughter, Mahi Kaur. She had just begun her first year of medical school in the United Kingdom.
It sounds like a typical parent-child exchange, but I imagine it quickly became something more. An intellectual exploration. What were they even discussing at first?
Well, initially they were just informal discussions.
Yeah.
About the density of the information she was facing, the sheer velocity of the curriculum, the lectures, and then this immediate confrontation with clinical placements.
So she was articulating that feeling of being thrown in the deep end.
Yes. Mahi was trying to put words to the challenge of absorbing this enormous volume of content while simultaneously being expected to be relevant in a clinical setting.
And the more they talked, the more this structural gap became obvious. It really highlighted a profound shift in medical education over 3 decades.
It really did. I mean, think about it. Dr. Kaur started his training in 1993. Mahi started in 2025.
That's a 32-year gap.
And that gap represents not just a passage of time, but a complete overhaul of how medical knowledge is structured and delivered to learners.
Let's dig into that. What were the educational structures they each encountered?
Well, Dr. Kaur's initial training in Calcutta in the early 90s was very different from today. It was heavily textbook-centered, it was discipline-based, and it was sequential.
Meaning?
Meaning you spend a year on anatomy, then a year on physiology. You were building this deep, foundational scaffold before you even seriously interacted with a patient.
What are the pros and cons of that model?
Well, it definitely fostered a kind of conceptual rigor. You had the basics down cold. But the big downside was that it delayed your clinical exposure. The relevance wasn't immediately obvious.
And Mahi's experience, which is, I think, pretty typical of modern UK and North American curricula, is almost the complete inverse of that.
It is. Modern training is characterized by very early clinical immersion, integrated curricula, and things like problem-based learning.
And the strengths there are undeniable.
Oh, absolutely. The relevance is there from day one. There's an immediacy, and it creates high motivation because students feel useful and connected to patients so much sooner.
But there's a but.
There's a but. That acceleration and integration, while positive in many ways, introduces some really significant conceptual challenges.
Can you elaborate on that challenge? Because it sounds a bit like we've traded one problem-delayed relevance for another, maybe conceptual fragmentation.
That's exactly the friction point.
Yeah.
That's the heart of it. The challenge that was identified in these conversations wasn't a lack of intelligence or motivation among students. Goodness, no. It was a fundamental lack of orientation.
Orientation. That's a great word for it.
Think about trying to navigate a vast, complex city without a map. Modern medical education, in a way, bombards the learner with facts and cases before they have built a stable conceptual scaffold.
A robust mental framework.
Yes, a framework to hold and organize all that incoming information.
So knowledge is just arriving piecemeal. A case you see on the ward, a protocol you get in a lecture, a slide deck that's full of high-yield facts for an exam. But there are no conceptual walls and beams to link it all together.
Precisely. And the material is so dense and it moves so fast that sustained contemplative reading of core texts is often replaced by just rapid consumption.
Summaries, flashcards, exam-focused notes.
Exactly. And this leads to a sense of constant triage. Students feel they are perpetually deciding what knowledge to discard just to save room for the next set of facts.
Instead of building a durable library of understanding.
Yes. They become excellent at retrieval for short periods for the exam. But the retention of meaning, of the deeper connections, it really suffers.
And at the same time this is happening, Dr. Kaur was simultaneously having his own kind of intellectual rediscovery, which fed directly into this project.
That's a key part of the story. For him, revisiting those foundational texts and disciplines through the lens of these conversations with his daughter, it was deeply stimulating.
And humbling, I'd imagine.
Very humbling. To realize how much the actual content of medicine had evolved and deepened in the 3 decades since he trained. Entire areas, from molecular immunology to advanced imaging and individualized therapeutics, they'd been completely transformed.
So returning to those core texts wasn't just for nostalgia.
Not at all. It was necessary to understand the cutting edge of the field today.
So you have this fascinating parallel process, a veteran clinician recognizing the evolution of depth in his field, and a new student struggling to establish the necessary depth in a system that's really just built for speed.
And that cross-generational exchange, that's what crystallized the shared recognition of a crucial missing middle ground.
Let's define that.
On one side, you have the dense, authoritative textbooks. They're comprehensive, they're irreplaceable, but they're almost impossible to enter in sustained engagement with when you have a busy training schedule.
They demand too much time, too much focused attention at once.
Right. And then on the other side, you have all the fragmented, efficient learning resources.
YouTube videos, the flashcard apps.
Great for quickly retrieving a fact or passing a spot quiz, but they're often shallow, disconnected, and the knowledge is quickly forgotten because it privileges immediacy over conceptual roots.
So the conclusion was that there was very little designed to help learners move between these two worlds.
Nothing to translate the complexity of the authoritative sources into a conceptual form that can travel with them. And this isn't just about making dense material accessible. It's about making the depth itself portable.
And so Clinical Deep Dives was conceived right there in that gap.
It was born as a way of translating the depth of traditional medical texts into an audio format, an unhurried, systematic way of thinking aloud through chapters, concepts, clinical patterns.
Something that could be absorbed gradually and revisited repeatedly.
And the aim, critically, is not to replace reading. This is so important.
It's explicitly to make reading possible again.
Yes. By providing the conceptual structure necessary for a confident engagement with the original sources. In essence, this whole project reflects a conversation across a generation of physicians.
Bridging the rigor of traditional textbook-based training with the demands of a modern, clinically immersive curriculum.
We exist to honor both and to ensure that sustained understanding bridges the gap between them.
Okay, let's shift gears a bit. Let's talk about the authority and the grounding of this project. Because if you're going to be a reliable guide for complex material, the perspective that informs that guidance is absolutely critical.
It is. The foundation of CDD is built on clinical, educational, and system-level experience that spans the globe.
And that breadth is vital, right? Why is it so important?
It's vital because our perspective is intentionally not anchored to a single curriculum or a single national health system or one academic tradition. It's been shaped by continuous movement across diverse systems and sustained engagement with how medicine is practiced and taught and learned internationally.
Which gives you a kind of universal viewpoint.
It provides a universal viewpoint on the cognitive demands of clinical work, the deep-down thinking part of the job.
So let's briefly touch on that trajectory, not as a resume, but more as a demonstration of exposure to these different systems.
Of course. It began with the foundation, the initial medical education in Calcutta, India, back in 1993. As we said, that was demanding in its requirement for conceptual rigor and a really close reading of foundational texts.
So it gave you that deep, perhaps slightly insulated appreciation for basic science.
It did. And then the subsequent training, which focused on psychiatry, was in Oxford in the UK. That was followed by over a decade of senior clinical leadership and directorship roles in Cambridge.
Which means sustained intensive exposure to frontline clinical care within the NHS.
Exactly. Frontline care, service leadership, postgraduate education, all within the framework of a major publicly funded system like the NHS.
And then came the comparison points, the stress tests for that knowledge structure.
Precisely. The career then involves significant experience navigating the competing demands and, the very different financial models you find across healthcare systems.
So NHS-funded services, Medicare-funded services in Australia.
In private insurance models, both in the UK and Australia. This gives you a really nuanced view of the operational constraints that shape clinical practice today.
The pressure of time, the drive for efficiency.
A constant negotiation between delivering depth of care and having to adhere to system constraints.
And I know you've also engaged internationally beyond just the Commonwealth nations. What did those experiences reinforce for you about the nature of medical practice?
I've been lucky to work on educational initiatives and service development across systems in places like Malaysia, Hong Kong, Peru, among others. And what those varied experiences reinforced is this central universal insight that underpins this whole project.
Which is?
That while healthcare systems, the funding, the protocols, the political structures, the patient flow, while all of that differs radically from place to place.
The core cognitive demands placed on clinicians remain remarkably consistent, global.
They're almost identical.
Can you define those universal cognitive demands for us? What are they?
They're the enduring necessities of clinical reasoning. Things like synthesizing vast amounts of complex information under pressure, managing clinical uncertainty when the data is incomplete or conflicting,
Which is all the time.
all the time, and integrating knowledge across traditionally separate domains. For example, reconciling a patient's socioeconomic context with their pharmacological compliance and their underlying cardiac physiology. The need to think flexibly and coherently, regardless of your location, that is the enduring demand of our profession.
So, given all that perspective, the stance of this project is very deliberate. It's not designed to be an exam cramming tool,
No,
and it's not bound to the syllabus of a single school or a single nation.
absolutely not. Clinical Deep Dives is designed to guide learning from experience. It's the viewpoint of a clinician who has moved through, taught within, and returned to foundational texts across multiple systems. The aim is simply to help you build the kind of robust, conceptual understanding that endures across a career, that adapts to new systems, and that holds firm through perpetually changing models of care.
You're training for the long haul.
We're training for the long haul, not the immediate hurdle.
Let's focus now on the central educational innovation itself. This concept you call the Clinical Conceptual Companion, or the CCC. We've defined it a bit abstractly, but let's articulate its function with some real specificity.
Okay, the CCC is the educational idea that runs through everything we produce. It is, simply put, a guided audio pathway through established medical knowledge that sits alongside traditional textbooks.
Not replacing them.
It does not replace them, nor does it attempt to summarize them superficially. Our whole mission is to help learners find their bearings within dense material so they can build durable understanding.
Which brings us back to what you termed the textbook problem. In modern medical education, those large, authoritative core texts, the foundational pillars of a specialty, they're often sidelined.
They become reference books at best.
Right. And we know that something important is lost when that engagement shifts from trying to understand the structured narrative to just mere retrieval and extraction of facts.
Oh, something huge is lost. When a textbook like Harrison's Principles of Internal Medicine or Robbins' Basic Pathology is reduced to a reference tool, or frankly a doorstop,
We've all seen that.
we lose the structured narratives that represent decades of collective expertise. These texts organize knowledge, they prioritize concepts, and they explain how a discipline thinks about itself. When learners skip that narrative, they lose the essential conceptual threads that connect, say, the cellular pathology of inflammation to the clinical manifestation of fever and pain, and then to the pharmacological logic of an NSAI. It all falls apart.
And the difficulty, as you noted before, isn't that textbooks are obsolete. It's just that they are so hard to enter.
They're incredibly dense. The terminology is layered, and they make layered assumptions about your existing knowledge base.
Can you give an example of that?
Sure. Think about tackling a complex chapter, say, on acid-base balance for the very first time. The sheer density is paralyzing. Where do you even start? What are the three core principles that everything else in that chapter rests on?
You don't know what's important and what's just detail.
Exactly. Without guidance, readers struggle to distinguish the core explanatory ideas, the structural beams, from the supporting detail, the paint color, and the wallpaper. So they try to memorize everything, and in the end, they memorize nothing of substance.
So this is where I want to push back a little. Isn't the CCC just a high-quality audio study guide? If the material is too dense and you're guiding the listener through it, how is your function interpretation and not just sophisticated summarization?
That is a critical question, and it speaks to the difference in our intent. Summarization aims to reduce the volume of information. It strips out detail to make the content faster to consume.
It's about efficiency.
It's all about efficiency. Interpretation, as we define it, does not strip content. It slows the material down just enough to reveal its architectural logic.
What does that look like in practice? Let's use a real example.
Okay, let's use congestive heart failure, a notoriously dense topic. A summary would just list the four main stages, the key symptoms like dyspnea and edema, and the standard classes of drugs, ACE inhibitors, beta blockers, etc.
That's retrieval knowledge. Stuff for a flashcard.
Exactly. Our interpretation, the CCC approach, is different. We would slow down the concept to trace the exact mechanisms. We'd ask, why does the failing myocardium trigger the renin-angiotensin-aldosterone system, the RAAS? We connect the compromised anatomy of the ventricle directly to the compensatory physiology of fluid retention.
You're telling the story of the pathophysiology.
We're telling the story. Then we look at the pharmacology of an ACE inhibitor, and we explain conceptually why it works. Not just by lowering blood pressure, but by interrupting that specific compensatory mechanism we just explained.
So you are establishing the hierarchy of ideas. You're showing which concepts carry the most explanatory weight before the learner even attempts to memorize all the details.
That's it. We are decoding the textbook's logic for you. The goal is to strengthen your conceptual understanding so thoroughly that when you finally encounter the specific dosages or the unusual side effects listed in the book, those details have a conceptual anchor to attach to.
They make sense.
They make sense, rather than existing as isolated facts floating in the void.
That makes perfect sense. It's like being handed the blueprint before you have to navigate the building.
That's a great analogy.
So the ultimate goal, then, is acting as a conceptual bridge. And by doing that, you're encouraging learners to go back to the original authoritative texts with greater confidence and clarity.
That is the payoff. By demystifying the structure and highlighting those conceptual anchors through audio, we radically reduce the sense of intimidation that surrounds a massive core text. The audio allows learners to revisit complex ideas repeatedly, on the move, in low-stakes moments, without the full cognitive load of sustained, focused reading.
That low-pressure, repeated exposure.
It helps you internalize the specialized language and the conceptual patterns. So when you finally do sit down to read the textbook, you're no longer intimidated. You feel oriented, you feel confident, and your reading becomes far more productive and, frankly, far more rewarding.
It reduces that feeling of alienation and encourages genuine engagement with the source material, which really is the cornerstone of lifelong professional development.
It's turning what was a passive act of reading a sentence into an active process of recognizing a pre-established conceptual relationship, a completely different experience.
Okay, now let's turn to the specific mindset that underpins all this synthesis and interpretation. You use this figure, Medlock Holmes. I love this metaphor, the doctor detective, as a way of naming that disciplined form of curiosity.
It's a necessary metaphor, I think, because it moves clinical work beyond being a purely bureaucratic process of following a flowchart. Medicine, at its core, is investigative work.
Symptoms aren't just complaints, they're clues.
Exactly. The history you take isn't just a form to fill out. It's a narrative that needs critical interpretation. The investigations provide pieces of a puzzle that have to be assembled with judgment, with methodological rigor, and with care.
The Medlock-Holmes approach captures that. Attentive, methodical, curious.
And, crucially, willing to sit with uncertainty long enough for coherence to emerge, not jumping to the first conclusion.
We know that time pressures and the relentless drive toward efficiency and protocol-driven practice can often erode this crucial investigative stance. Curiosity, ironically, can start to feel like a professional luxury.
That is the tragedy of modern high-pressure medicine. It truly is. When the workload ramps up and the system demands throughput, clinical thinking shifts from exploration to just execution.
You're just getting through the list.
Learners become focused purely on tasks, checklists, protocols, fast diagnoses, and the sustaining force of intellectual curiosity gets eroded. And when curiosity dies, the joy of the profession diminishes, and I would argue the quality of judgment suffers.
So Clinical Deep Dives seeks to restore and protect curiosity as a core professional skill. But we're not talking about just asking frivolous questions. You're talking about curiosity as synthesis.
Precisely. We are encouraging the learner to ask better, more conceptually grounded questions. Instead of simply accumulating more facts in an already crowded mental space, the Medlock-Holmes approach emphasizes weaving what you already know across traditional domains.
You ask why.
You ask why. If the pathology is X, how must the physiology be compensating? If the anatomy dictates this finding on examination, why is the patient presenting with an altered mental status that usually suggests a functional issue?
So it's about connecting anatomy to examination, physiology to pharmacology, pathology to clinical trajectories.
When knowledge is woven into that coherent conceptual fabric, it becomes truly durable and transferable. Let's take a specific example. A patient presenting with hyperkalemia, high potassium. Accumulation knowledge says, look up the treatment protocol.
Get the calcium gluconate.
Right. Synthesis knowledge says, wait a minute, why is the potassium high? You connect the patient's history, say chronic kidney disease and use of spironolactone, to the underlying physiology, which is impaired excretion and a block of aldosterone receptors. Then you connect that physiology to the cardiac effects. the risk of arrhythmia, which then dictates the urgency of the treatment.
It's the full picture.
It's the full, integrated, synthesized reasoning.
And this deep conceptual approach benefits different career stages in distinct ways. Let's start with medical students who are just struggling with that sheer volume of information.
For medical students, especially those facing that initial overwhelming density, the CCC builds essential vocabulary and structure early on. It demystifies medical language, which is often the first and most significant barrier to entry.
It's like learning a new language.
It is. By listening to the audio on a daily walk or commute, they can weave learning into their daily routines. This makes the subsequent intense textbook reading immediately more productive, and it builds their confidence with professional medical language. We reduce the intimidation factor by providing conceptual confidence first.
Then we move to the doctors in training, the residents or registrars who are deep into their specialization. They face the risk of narrowing their focus too quickly.
That's a huge risk. As specialization intensifies, say, a year dedicated purely to surgical rotations, it's extremely easy to lose touch with foundational areas like internal medicine or pharmacology or population health.
But modern practice demands that broad, integrative thinking.
Especially when you're managing complex multimorbidity, CDD offers a way to maintain that breadth to keep those foundational concepts active and accessible. Trainees can integrate new information flexibly without needing these sustained, intensive, non-clinical study blocks. It keeps them whole, conceptually.
And finally, what does this deep dive approach offer the experienced clinicians, the people years into practice who've already passed the toughest exams?
For experienced professionals, the learning shifts. It becomes about intellectual renewal and professional longevity. Revisiting core concepts through the CCC offers an intellectual nourishment that goes way beyond just mandatory continuing education credits.
It's not just ticking a box.
No. It helps them reconnect with how medical knowledge, specifically the foundations they were trained on, has evolved in light of new molecular and genetic insights. It challenges their assumptions, it supports a critical evaluation of new guidelines, and it keeps that vital sense of curiosity alive across a decades-long career. It's a source of professional vitality.
Okay, here's where it gets really interesting, I think. How does this approach, which is so focused on structured depth and conceptual mastery, fit into a world that's dominated by instant information retrieval and advanced technology, specifically artificial intelligence?
That is the single most critical question facing medical education today. We are in a transitional period, and there is, understandably, a lot of anxiety among learners.
Anxiety about what, specifically?
About what human expertise will still matter when technology can retrieve facts, synthesize data, and even suggest diagnoses faster and potentially more accurately than any individual human can.
And you are completely transparent about this project's relationship with AI.
We must be. We have to be explicit. Clinical Deep Dives is created with the assistance of AI, but it's not created by AI alone.
What's the distinction?
We utilize AI as a powerful tool for synthesis, for clarity, for structuring, and for consistency. This allows us to explore complex, dense materials systematically and at a scale that ensures the depth and coherence of these companions. We are harnessing the best tools available responsibly. But the educational intent, the conceptual structuring, and the final clinical judgment remain entirely human-curated.
That's a crucial distinction. It suggests that the purpose of CDD isn't to compete with AI's retrieval capabilities,
Not at all.
but to strengthen the human capacity to use those outputs intelligently.
That is the core educational position. And for us, it's a non-negotiable one. As access to information becomes instantaneous, the need for conceptual understanding becomes exponentially greater, not less.
Why?
Because AI excels at retrieving facts and identifying statistical patterns in vast data sets. What it does not replace is human meaning-making. That critical integration of retrieved knowledge with experience, with clinical values, with ethical context, and with the inherent uncertainty of biological systems. Medicine has always been an interpretive relational science, not merely an informational one.
So clinical judgment remains the ultimate human edge. How does CDD specifically strengthen that judgment in an AI-driven environment?
Clinical judgment depends fundamentally on having deep, robust conceptual frameworks. Imagine a scenario where a large language model gives you 3 differential diagnoses and it scores them by probability. If your conceptual understanding is shallow, you will simply defer to the highest score. You become a technician.
But if your understanding is deep,
If your understanding is deep, if you know the physiological mechanism, the pathology timeline, and the epidemiological context that we discussed in the CCC, You are equipped to evaluate that AI output critically. You can ask, does this probability really align with this patient's context? Is the AI perhaps overweighting a common but benign finding and missing a rare but catastrophic one?
So you are strengthening the learner's capacity for evaluation. You're ensuring they can contextualize and, if necessary, challenge the AI's recommendations intelligently.
Exactly. When understanding is shallow, even the most sophisticated tools can dangerously mislead the user, or worse, encourage a kind of intellectual laziness. We are ensuring that the clinician remains the informed, critical decision maker in the loop.
It's interesting that you noted that the level of structured synthesis now achievable through AI assistance sometimes exceeds what was previously possible even in traditional lecture formats. That sounds like a powerful argument for integrating it.
It is not a criticism of dedicated human educators, but it's a recognition that the tools for structuring and explaining complex concepts have fundamentally changed. Think about constructing a conceptual map of, say, the entire continuum of chronic inflammatory diseases. Historically, a lecturer might cover one facet of that in a 50-minute slot.
And you'd get another piece of the puzzle next week.
Right. With AI synthesis tools, we can systematically explore that entire conceptual architecture, ensuring all the key mechanisms are defined and linked clearly before the human expert applies the clinical judgment and curates the final narrative. We aim to responsibly harness AI-enabled synthesis with human-curated intent.
You're preparing learners for the future.
By strengthening the enduring elements, conceptual clarity, and the capacity to think deeply.
Okay, let's pivot back to the practical nature of the audio format itself, which facilitates this learning on the move. Because time really is the major systemic constraint in modern medical life.
The audio format is designed specifically to solve the time crisis. It meets learners where they already are. It fills the spaces where sustained, focused reading is physically or cognitively impossible, on a walk, commuting, waiting between cases, or running on a treadmill.
And this shifts learning. It stops being a concentrated, high-effort event that requires dedicated, protected time.
And becomes a continuous, low-pressure exposure woven into daily life.
And we know from a learning science perspective that this continuous, low-pressure exposure is often much better for long-term retention than high-intensity cramming.
Psychologically and cognitively, it is far superior for retention. Concepts are encountered repeatedly in different contexts, initially by audio, then later perhaps in the textbook, then again in a clinical scenario. This supports the long-term encoding of information better than infrequent, intense study.
And it helps internalize the specialized language.
It helps internalize the language and the conceptual structure almost passively, which reduces the initial cognitive load when the learner transitions to the active reading phase.
So learning becomes woven into the daily routine rather than constantly competing with it and leading to burnout.
It transforms previously dead time into productive intellectual development time. It ensures that curiosity and deep conceptual learning can continue quietly in the background of a busy, demanding professional life. It complements, rather than competes with, traditional study and clinical work.
Now let's address the practical side. How is this resource sustained? Clinical Deep Dives is built on a strong commitment to openness and accessibility, but that has to be balanced with the practical need for project viability and sustainability.
Transparency is really important here. Our commitment to wide accessibility is why the Foundational Medicine series, the core Clinical Conceptual Companion, has been made fully open access.
So the basics are free for everyone.
We made the decision that the concepts underpinning general foundational medicine should be available to everyone globally without restriction. This foundational series serves as a clear, complete demonstration of the project's depth, its tone, and its systematic educational approach.
And this openness isn't just restricted to that one core series.
No, we keep selected strategic chapters from every subsequent book, including the surgical, psychiatric, and other specialty texts freely available as well.
Why do that?
These open chapters allow listeners to thoroughly explore the CCC approach for advanced topics and to use specific high-yield topics as standalone refreshers or crucial points of orientation. It ensures transparency and utility across the whole growing library.
But to allow the sustained creation of these systematic long-form companions to major texts, which requires significant resource investment in time, curation, synthesis, and expert input subscriber support, is necessary.
Correct. The full Advanced Medical and Surgical Clinical Conceptual Companion series are supported through a small subscription model. This support is simply vital for the sustained creation, the careful curation, and the ongoing maintenance of the growing audio library. The intent is to ensure that the rigorous work involved remains viable over a long time horizon. We're prioritizing continuity over rapid profit.
So you're framing this not as a typical transaction, but more as an exercise in shared stewardship, collective participation.
Exactly. We've kept the subscription deliberately small, often less than the cost of a daily coffee or a journal subscription over the course of a year. It's framed as a shared contribution to a collective project. By supporting it, subscribers help sustain a growing, high-quality educational library that benefits a wide community of learners across different nations and career stages today and into the future.
And because the subscription is intentionally low, viability depends on scale. It needs a wide community of modest support, which ensures low barriers to entry and maximum inclusivity.
That is the key mechanism we rely upon: shared commitment and goodwill. When clinicians or students or educators find value in this approach and they recommend clinical deep dives to their colleagues, they help expand the community that makes this ambitious, systematic, long-term work possible. This balance ensures the project remains inclusive while still having the stable financial structure necessary for us to continue producing the material at the required depth and quality.
So after all that, what does this all mean for the listener beginning this journey with us?
I think it means that Clinical Deep Dives is designed to be a stable, curious presence that you can return to again and again.
The mission is ultimately about continuity. It's about helping you feel oriented, curious, and conceptually connected, rather than overwhelmed or fragmented by the sheer speed and volume of modern medicine.
And that connection, as we discussed earlier, it all hinges on protecting your curiosity. Across the arc of your training, through specialization, and across decades of practice, curiosity is not merely a personality trait. It is a source of professional vitality and clinical wisdom that must be intentionally shielded from the pressures of pace and protocol.
So this project is shaped by those crucial conversations across generations. It's informed by practical experience across multiple global systems. And it's driven by a deep conviction that understanding matters most, especially in an age of accelerating technological change.
It reminds us that while tools and guidelines will continue to evolve, the need for clinicians who can think integratively, reason flexibly, and connect abstract knowledge back to the complexity of human experience, that remains the constant defining feature of expert medical practice.
The Medlock Holmes ethos runs quietly through all of this work.
It does. We are supporting the enduring need for thoughtful investigators. Clinicians who are willing to pause, to question the assumptions, to look for the conceptual patterns, and to value depth over haste.
We offer companionship rather than mere instruction.
Yes, we're supporting your lifelong process of revisiting, reintegrating, and re-understanding medical knowledge.
It's a powerful, unhurried invitation to keep that professional relationship with medicine intellectually alive and conceptually robust.
Which leaves us with this final important thought, something for you to carry forward as you embark on this learning journey with us.
In an accelerating world, one dominated by AI-driven retrieval and data saturation, how are you intentionally cultivating a relationship with medical knowledge that is built to endure, not just to pass?